Well, welcome to Indianapolis, those of you who are from out of town. Don't you just love it? Don't you just love it? All right, all right. Welcome to the 5th annual, and it's a sold-out job, Labor of Love Infant Mortality Summit. Thank you for finding our new location. I'm Barbara Boyd, and I'm going to be your MC for today. Well, now today's format is styled as a modified TED talk presentation. Each speaker will give their presentation and gather on stage for the follow-up questions. Each table has a centerpiece. Look at that, you got your centerpiece? Each table has a centerpiece with the event hashtag for you to submit questions to presenters. So please note which speaker you are directing your questions when you send them. Now, our speaker this morning will bring a wealth of knowledge and experience to our stage, so make sure you tweet your questions too. Maybe you want to get your pencils out for this. You send your questions to hashtag capital IN Labor of Love 17. Labor and love are capped, okay? You have to have your questions answered by those presenting today. The Wi-Fi password is also on the centerpiece, Love 2017. It's not case sensitive. Today's lunch is co-sponsored by Riley Children's Foundation and Riley Children's Health. Now, following lunch, this room will be separated to accommodate the immunization breakout and the reception at the conclusion of today's activities. The Women, Infants, and Children session this afternoon will be downstairs along with most of the other breakout sessions. The reception this afternoon is being held in the Marriott Ballroom, rooms 1 through 4, on the left side of this room. On the left side, my right, your left. Now, just a few additional announcements. We have a very unique request. Turn off them cell phones. Now, okay? Okay. And if you need to charge your phones sometime today, we have a couple of charging stations in the registration area. We have 21 poster presentations today, and they will be available for viewing throughout the day. So I encourage you to go and take a look at them. Look them over. They have worked hard to get them out there for you. So, you know, let's take a look. There are 2 lactation rooms available, Columbus on this floor and Colorado on the 1st floor. In our effort to be a green meeting, please, please, please recycle your name badges when you leave. There's a box for you to deposit them in right outside of this room. So please visit the sponsors and exhibitors. They worked hard to put up those things for you, so, you know, take a visit. We count on them to make this event what it is today. We will have several prize packages for you during the reception, but remember, in order to get a prize, you got to be here. Now, also another thing for you to remember, the shuttle leaves at 6:30. You miss the shuttle, you better have good legs. You might have to hook it, okay? So don't miss your shuttle at 6:30. And at this time, I would like to thank today's sponsors, St. Vincent, Women, Infant, and Children, Anthem Blue Cross Blue Shield, Community Health Network, the Milk Bank, and our luncheon co-sponsors, Riley Children's Foundation and Riley Children's Health. So please join me in thanking today's sponsors. Put your hands together and give them a big thank you. You know, you can hardly have a successful fundraiser or any kind of big event where you're trying to get the word out without a sponsor. It's just absolutely smart. They are crucial to any successful event. So be sure to visit our sponsors, say thank you when you see them, shake their hand, give them a kiss, do whatever it is to make them comfortable. And I want you now, again, to save the date for next year's summit, Wednesday, November the 14th, 2018. See how we plan ahead? And you can watch the summit website. Again, you might want to take out your pencil. That would be at www.infantmortalitysummit-indiana.org for the announcement about 2018's registration. Got that? All right. If now my pleasure to introduce our first speaker. Dr. Kristina Box is the newly appointed Indiana State Health Commissioner. She began her duties just 1 month ago. Dr. Box has been a practicing obstetrician and gynecologist in Indianapolis for 30 years. She don't even look 30. She earned her medical degree at the Indiana University School of Medicine in Indianapolis. So ladies and gentlemen, put your hands together and welcome Dr. Chris Box.
Thank you.
You're welcome.
It's so kind of you. I have to keep you around, make me feel better. So I want to echo Barbara's welcome today for everyone. We are so blessed to have you here for the 2015 fifth year of our Infant Mortality Summit, Labor of Love. This started 5 years ago with 500 attendees, and we're now up to right around 1,300. I think that's an amazing feat, and I really want to thank you for being here because I know your heart is for our unborn children and our pregnant moms. My goal today is to spend a little time just introducing you to infant mortality and to specifically discuss our 2015 statistics. I will spend a little time talking about what IPQUIC, which is our Indiana Perinatal Quality Improvement Committee, is doing with ISDH throughout the state and Indiana hospital associations, and then talk a little bit about what we may need to do going forward. We have some amazing speakers coming after me this morning, and the breakout sessions this afternoon, I still can't decide which one I'm going to go to. They look so fabulous. This is a quote that I took directly from the IPQUIC 2016 report, and I really love it, and I wanted to read it to you today. The problem of infant mortality is one of the great social and economic problems of our day. A nation can waste its forest, its water power, its mines, and even its land. But if it's going to hold its own, its children must be conserved at all costs. Because on the physical, intellectual, and moral strength of our children of today, the future depends. And that was from a lady named Julia Lathrop, MD, a director of the Federal Children's Bureau back in 1913. Throughout the world, infant mortality is considered a key indicator of a nation's, or in our circumstance, a state's well-being. Infant mortality is defined by the CDC as the death of a baby before his or her first birthday. The infant mortality rate is an estimate of the number of deaths per 1,000 live births for a population. And as mentioned, that rate is often affected by our health of our state. So for instance, if our state has a high obesity issue, which leads to diabetes and hypertension, or a very high smoking rate, that will affect our infant mortality rate. I wanted to do something with you that I saw Curtis Hill, our Attorney General, do with a recent speech. And then he gave about 4 or 5 numbers, and throughout his talk kind of filled those numbers in. And it gave me, as a listening viewer, some numbers to take away that I could share with my family and my friends and my colleagues of what I learned during that conference that day and what were some important takeaway points. So those numbers, if you want to write them down, are 7.3, 2.1, 613, 14, and then 14 again. And I have one word: disparity. Indiana has consistently been one of the worst states in the nation for infant mortality. In fact, we've ranked in the bottom 10 for the last 50 years. In 2015, Indiana's infant mortality rate was 7.3 per 1,000 live births. And across the United States during that same time period, it was 5.9 per 1,000 live births. The Healthy People goal is 6 deaths per 1,000 live births. So you can see we have quite a ways to go. Unfortunately, if you were a Black infant in 2015, your chance of dying was 2.1 times higher than a white infant. So the 613 comes in because I don't think 7.3 really impacts people when you talk to them. But if you say 613 babies died before their first birthday in 2015, that's a number we can take away. That's over 50 babies every month and just under 12 babies a week. And if you look over the past 5 years, that amounts to about 3,000 infants who died before their first birthday in the state of Indiana. Now, this slide shows infant mortality rate based on race from 2006 to 2015. And what I'd like you to notice is that the blue line is the state of Indiana. We've only been below 7 twice in the last 10 years. That was in 2008 when we were 6.9, and 2012 when we were 6.7. Unfortunately, we have actually ticked up a little bit this past year. If you look at the red line, that's the white infant mortality in the state of Indiana in 2006 to 2015. If you'll notice from 2012, 13, and 14, we were actually below the healthy people goal of 6.0. Unfortunately, again, that ticked up in 2015. Unfortunately, when you look at the Black infant mortality rate, the good news about that, that's the green line, is that we started in 2006 at 18.1 deaths per 1,000 live births, and now we're down to 13.2. So that's an improvement. But unfortunately, it still remains that significant disparity of 2.1 times more likely for a Black infant to die. I think this is an interesting slide. It was put together by ISDH. And basically, it shows infant mortality rate based on counties and zip codes. The counties outlined in purple are the 6 counties that contain the 13 highest zip codes throughout our state. And the blue counties have at least 5 deaths in their zip codes throughout their county. But most importantly, what I want you to see is that of these 29 zip codes, or high-risk zip codes, which account for about 2.9% of all the zip codes in the state of Indiana, those 29 zip codes account for 27% of our infant mortality in the state. So if we want to know where to focus our efforts, I think that's a pretty clear picture. Again, this is looking at the infant mortality from 2011 to 2015, and you can see some of the high-risk counties here and the white and Black infant mortality risk disparities. You'll notice that there are 6 of those counties right here in Marion County. I think maybe Okay. So what factors contribute to the infant mortality rate in the state of Indiana? Well, Indiana is listed on this state as the 15th most obese state in the nation. Unfortunately, I just found out yesterday we are now the 10th most obese state in the nation. So obesity contributes to preterm birth. And we know that if you're obese, you have a 25% chance of having a preterm baby. And if you're morbidly obese, you have a 33% chance of having a preterm baby. So that contributes significantly to infant mortality because we know that the #1 cause is preterm birth and low birth weight for deaths. Also, 14% of women smoke during their pregnancy in the state of Indiana, and that's double the national average. If you look even worse, 25% of our mothers on Medicaid smoke during pregnancy. We know that smoking causes an increased risk for miscarriage, causes placental problems which lead to fetal growth restriction, increases the risk of preterm birth and low birth weight, and increased risk of sudden infant death syndrome, another big contributor to our infant mortality, and increased birth defects like cleft lip, cleft palate. In Indiana, only about 69% of our patients receive care in their first trimester. The healthy people goal for that is about 78%. If you look at the white population, that's about 69% of women get care. And unfortunately, in our Black population, that drops to 60% in their first trimester. And unsafe sleep practices continue to cause a significant issue with infant mortality in the state of Indiana. 14% of our infant deaths in 2015 were attributed to sudden unexpected infant death syndrome. It seems simple to me, the ABCs, alone, on their back, in a crib. The causes of infant mortality by race in Indiana in 2015 are divided here between the white and Black population. And what I want you to notice about this slide is that the largest contributor is perinatal risks, which include preterm birth, premature rupture of membranes, neonatal sepsis, and low birth weight. Unfortunately, in the Black population, we do see that to be a higher percentage of births, and that's because Black moms are more likely to deliver a low birth weight or very low birth weight infant than white moms. The other thing I'd like you to notice here is that the risk for sudden unexpected infant death syndrome is twice the risk in the white population. What is the Indiana State Department of Health doing to try to address some of these issues? The Indiana State Department of Health, as you probably know, partnered with Indiana Hospital Association to develop IPQUIC, the Indiana Perinatal Quality Improvement Committee. And in 2014, they addressed elective deliveries below 39 weeks gestation. They said that those deliveries being done just out of convenience or it worked better for the patient, better for the doctor, needed to stop. And in all honesty, that has decreased the risk for NICU admissions, decreased the risk for sepsis, infection, and even sometimes mortality. Per the Indiana Hospital Association's data, we have an indication that those have decreased significantly throughout our state. We also know that the number one risk for having a preterm baby is having had a preterm baby before. And evidence shows us that the use of 17-hydroxyprogesterone used during early pregnancy and throughout pregnancy can decrease the risk of a second preterm birth. So IPQEC has a committee that is focusing on protocols and, most importantly, access to 17-hydroxyprogesterone throughout our state. Unfortunately, the most vulnerable of our population, our pregnant moms and their unborn children, have not escaped our opioid or substance use addiction epidemic that we have going on. So IPQEC piloted a program initially with 4 hospitals looking at the use of substance use disorder in pregnancy and also the resultant neonatal abstinence syndrome. That has actually expanded to now 26 hospitals, possibly soon to be 27 by the end of December. And the information coming out of that is overwhelming and very concerning for the state of Indiana. I really don't want to delve much further into this, but we definitely have an emphasis on that today. And Dr. Maria Del Rio Hoover will be speaking some more about that specific project. We're trying to improve breastfeeding throughout the state of Indiana. Healthy People goal is 82% of women breastfeeding at the time of discharge. Unfortunately, in Indiana, we're at about 81%, and the Black population is at about 69%. We know that breastfeeding decreases the risk for sudden infant death syndrome and decreases the risk for infection. Safe sleep guidelines are very important because, unfortunately, an unsafe sleep environment contributed to about 1 out of 8 of our infant deaths. Again, alone on their back in the crib. Dr. Walthall told me about a sleep sack that she saw, and I don't know if there's proprietary control over this with patents, but the sleep sack says this side up, just like your popcorn. And I think that's a great idea to remind grandma and mom and dad and uncles and aunts, brothers and sisters, this is the way the baby sleeps. We're also addressing long-acting reversible contraception. We were very blessed that the Indiana Healthy Coverage Programs unbundled the placement and the device cost of placing a LARC immediately after delivery from the actual delivery cost, which has incentivized our providers and patients to go ahead and get that placed right after their delivery. The purpose of that is to allow women to better plan their next pregnancy, hopefully increasing that pregnancy birth interval by at least 18 months. We're working to establish appropriate levels of care throughout the state, and IPQEC has been working very hard on this for the past 2 years. They've actually surveyed all 90 delivering facilities within our state and determined if you said you were a level 3 nursery, did you actually meet those requirements? If you said you were a level 3 obstetrical unit, did you actually meet those requirements? And showed the hospitals and the birthing centers where they fell short. I think this is really important because the American Academy of Pediatrics, the American College of OBGYN, and our Society for Maternal Fetal Medicine have all endorsed this as something that decreases infant mortality and infant morbidity just by making sure that infants are born at the appropriate level of hospital or birthing center for their risk. I'm happy to say that the governor has taken this on as part of his agenda, and moving forward, and the legislature will be supporting this. So we're hoping to have this passed early in 2018. Also, I think that we should add to this list using baby aspirin, reminding our providers that women that are at risk for preeclampsia, if they take 81 milligrams of aspirin on a daily basis, can decrease their risk for preterm birth by some reports as much as 60%. So in summary, 613 infants in Indiana died before their first birthday in 2015. Nearly 14% of our infant deaths can be attributed to sudden unexpected infant death syndrome, many of them secondary to unsafe sleep environments. We have a much higher percentage of women in Indiana who smoke during their pregnancy and a lower percentage of women who get prenatal care in their first trimester. There continue to be large disparities in all of our indicators, and that makes approaching a plan on trying to solve these complex issues very difficult. We must address the persistent racial, socioeconomic, and geographic disparities and inequities that occur in our state. In some cases, that may mean better coordination of care in their existing state or just removing barriers to that care. But in other parts of our state, that may actually mean that we have to get care in closer access to our patients and their families so that they do get that health care they require. This is going to require a collaboration at the grassroots level, not just between healthcare providers and hospitals, but between community-based organizations, faith-based organizations, and all of our businesses. Thank you very much for allowing me to speak to you today. I now have the pleasure of introducing Chris Kirshner from Community Hospital Network, and she's going to introduce a very special guest that we have with us today. Thank you.